Hello class, I'm going to provide you the lecture for week 6, day 2 on the concept of mobility with our exemplar of normal versus abnormal mobility, and then our second exemplar of osteoarthritis. Again, I want you to be sure that you look at that YouTube video. It's only a short video, about 2.5 minutes, that just gives you an overall view of the musculoskeletal system. And explains about the importance of bones, muscles, joints, tendons, ligaments, and cartilage, which all take an active part in the art of movement and our mobility. Of course, our bones do provide that framework, and between those bones we have joints and tendons, ligaments, and cartilage, and they connect bones with either muscle or other bones and provide cushioning as we move. I'm sure this goes back to your anatomy and physiology, where with the skeleton we have 206 bones, and bones form the body structure. They support soft tissues, and they protect vital organs, and they provide a point of attachment for the muscles, storing minerals and forming blood cells. Our muscles are critical for mobility, and there's 3 types of muscles: our skeletal, our smooth, and our cardiac. The skeletal attached to bones by tendons, and when that particular muscle contracts, it causes movements of those skeletal bones. There's about 640 skeletal muscles within the human body, and voluntary control is by the nervous system. And again, we have over 500 muscles in our body, and we can then label them as either involuntary or voluntary. Our joints are formed when 2 bones meet, and they hold the skeleton together while still providing the ability to move around. Ligaments, tendons, and cartilage all are connective tissue composed of differing amounts of collagen fibers, proteoglycan matrix, and the cells are either fibroblast or chondroblast. Our ligaments connect bones to other bones to form a joint. They strengthen, stabilize the joints, and may limit the mobility of some joints. And then our tendons connect bones to muscles, and they carry a contractile force from muscle to bone that cause an individual to move. Okay. Cartilage are flexible connective tissues found throughout the body, less flexible than muscle, but they're definitely not as rigid as bone. And of course, your cartilage does not contain blood vessels. So I just wanted to kind of remind you of the various structures that are all an active part in mobility, and when any of those structures are altered, we may have some impairment of mobility. And what I have up here on the screen is a activity which really looks at the physiological consequences of immobility on all the various body systems, and how important this particular ability to move can affect these other systems quite drastically. And we've seen and talked about mobility within some of the other specific systems. So let's take a look at each of these systems and see the kinds of changes that occur when an individual is immobile. So the first body system is the integumentary system. So let's think about this. So first of all, with immobility occurring, we would see an increased pressure on the skin, which would be aggravated by metabolic changes. There would be decreased circulation to the tissues, causing ischemia, which can lead to what? Pressure ulcers. Absolutely. Good job. All right, let's look at the respiratory system. What happens to someone who's laying in bed? What effect does this have on the respiratory system? Decreased respiratory movement leading to decreased oxygenation and carbon dioxide exchange. You have a stasis of secretions, and those muscles become weakened in the chest, resulting in atelectasis and hypostatic pneumonia, and of course a decreased cough response. It's very, very difficult to give a good forceful cough when you're laying in bed and you're immobile. So of course right there we have problems with diffusion of gases, and we have a lot of complications occurring. And it presents the best situation for someone to definitely acquire pneumonia. All right, the cardiovascular system. It can affect blood pressure, causing someone to develop orthostatic hypotension, less fluid volume in the circulatory system. Think about the flow of blood, stasis of blood in the legs, decreased cardiac output leading to poor cardiac effectiveness, which results in increased cardiac workload and increased oxygen requirement. And of course, because of stasis of blood flow in the circulation, it presents an increased risk of thrombus formation. Very serious situations. And that makes sense, because that's why we put our patients prophylactically on sub-Q heparin or Lovenox. All right, metabolically, what kind of changes occur? There's an altered endocrine system, obviously a decreased metabolic rate. There's definitely changes in protein, carbohydrate, and fat metabolism, a decreased appetite with altered nutritional intake, negative nitrogen balance, decreased protein intake resulting in muscle loss, loss of weight, alterations in calcium, fluid, and electrolytes, reabsorption of calcium from the bones, making the bones then more brittle, and decreased urinary elimination of calcium, resulting in hypercalcemia. So a lot of things begin to occur metabolically with immobility. Elimination, urinary stasis, reabsorption of calcium resulting in renal calculi or someone developing kidney stones, decreased fluid intake, so you have poor perineal care, and indwelling catheters could result in urinary tract infections, decreased peristalsis, so the development of constipation and fecal impaction are at a greater risk from occurring. And then muscular skeleton, decreased muscle strength and mass. The muscles begin to atrophy, impaired balance and stability, osteoporosis, fractures, foot drop, and altered joint mobility. Neurological and psychological, changes in emotional status, depression, alterations in self-concept, anxiety, behavioral changes. A person may become withdrawn, altered sleep-wake patterns, hostility, inappropriate laughing, and passivity. So let's look at these developmental changes that may occur as well, starting with a child. When a child is immobile, slower progression of motor skills and intellectual and muscular skeletal development, body aligned with gravity resulting in unbalanced posture, social isolation, and delayed development of independence. With the adult, alterations in family and social systems, and alterations in job identity. And with the older adults, alteration in balance resulting in major risk for falls and injuries, steady loss of bone mass resulting in weakened bones, decreased coordination, slower walk with smaller steps, alterations in functional status, and more dependence on staff and family. So we do see some significant changes occurring with immobility that does affect all body systems. And really looking at the older adult, we do see bones begin to thin and become weaker. And of course, our concern is the increased risk of bone fractures. And this definitely happens to women after menopause, where they do develop osteoporosis, and we will be talking about that next week. There's also changes in their spinal disc, and discs are what hold the vertebrae together. They kind of serve as shock absorbers. Leads to spinal column compression, and that's why people, as they begin to age, they're not as tall anymore, because it results in shorter stature and a stooped type of posture. Muscle fibers begin to decrease, where you see atrophy, as I said earlier. Sarcopenia, where less time and decreased speed and power of contractions. And remember, the tendons and ligaments have decreased elasticity, strength, and decreased hydration, causing them to be more stiff and with decreased flexibility and, of course, decreased range of motion. And ligaments and tendons tear more easily, and you have an accumulation of fluid in the joints. Decreasing cartilage rubs, cartilage begins to rub together, and then you have erosion pain and inflammation, where the person really begins to walk very slow and at times unsteady. So this is why it's so important that, especially with the older person, we really get these people moving, turning, repositioning. We know, to sum it all up, immobility can lead to atelectasis, pneumonia, decreased GI motility, causing some effects of paralytic ileus, decreased tissue perfusion, and we know they're definitely at risk for pressure ulcers. So some of the common problems that we see with immobility is back pain, at risk for fractures, multiple sclerosis, osteoarthritis, Parkinson's, and spinal cord injuries. And then there are some conditions that will limit mobility, and that could be someone having a really significant amount of pain, fatigued, any type of respiratory disorder, a cardiovascular disease, a nervous system disorder, or some kind of musculoskeletal problem. They may need the help of a physical or occupational therapist. And sometimes this affects their psychological help, where they're unable to cope with these limitations and may need counseling. And back problems can be caused by various problems: trauma, degenerative disorders, muscle irritation, even pregnancy, poor physical fitness, or someone who's just basically overweight. Fractures are obviously a break in the continuousness of the bone, where there is, and the severity will depend on the nature of the event and the strength of the bone to begin with. We see, unfortunately, some of the autoimmune diseases, and one that may be familiar to you is multiple sclerosis, which is an autoimmune disorder that destroys the myelin sheath around the nerves, and it will disrupt transmission of impulses between the sensory and motor disturbances, causing a person to develop bowel and bladder issues. And with osteoporosis, we see that people are very at risk for various fractures. And one of the most common fractures we see with the older adult is hip fractures. So I just wanted to kind of go over some of those things when we talk about normal versus abnormal mobility. So continuing with our concept of mobility, let's look at our exemplar of osteoarthritis. It's the most common form of arthritis. It develops as wear and tear on joints with breakdown of cartilage, bone on bone. We see it occur most frequently within the hands, the knees, and the hips. Osteoarthritis is a degenerative joint disease, and we can either classify it as localized, generalized as idiopathic. Osteoarthritis has no identifiable cause, but a lot of people believe it is caused by both mechanical and molecular factors. Idiopathic osteoarthritis can be divided into localized or generalized, with localized OA affecting one or two joints, and generalized OA affecting 3 or more joints. Secondary OA is caused by an underlying condition such as an injury, a congenital malformation, metabolic, endocrine, or neuropathic disease, or some other medical cause. It's a progressive erosion of joint. Articular cartilage can also have bone spurs occur. And again, these are just what I said about primary or idiopathic. There really is no single clear cause. Secondary arthritis, underlying condition, trauma, bone disease, or some kind of inflammatory joint disease. So what are the risk factors? Who gets osteoarthritis? Idiopathic osteoarthritis is basically associated with age, and excessive weight does contribute to OA. So it's important to maintain ideal body weight and participate in modern exercise program. Inactivity and excessive exercise can lead to premature degeneration of cartilage. So really the greatest risk factor for OA is older age. This rarely occurs in an individual under the age of 40, but at least 80% of individuals over age 55 have some X-ray evidence of this disorder. 60% of individuals who have osteoarthritis are women. Men will develop osteoarthritis in the hips, knees, and spine, where women usually develop osteoarthritis in the hips, knees, and hands. Any job that requires hard labor, heavy lifting, bending, or repetitive motion will have an increased risk of developing OA. And of course, as I said before, obesity also increases the risk of developing OA. Just wanted to talk a little bit about the clinical manifestations. OA usually begins with mild symptoms and progressively worsens over time. Symptoms of OA will vary depending on which joint is actually affected and some of the individual factors. But most people do have a gradual and insidious onset where there is pain and stiffness in one or more joints, and pain can also be referred to other parts of the body. Complications of osteoarthritis is joint pain, degeneration, and unsteadiness. And because of the unsteadiness, it puts a person at an increased risk of falling, which is a very serious problem. So it's really about the person's safety. Really, there's no treatment out there to stop the progression. early treatment can be beneficial, and people just have to learn to live with chronic diseases like osteoarthritis. And some of the non-pharmacological therapies are obviously educating a person about what triggers that pain, or keeping your weight definitely under control, to encourage people to maintain an ideal body weight and participate regularly in a moderate exercise program. And what is suggested with the type of exercises that a person does is more of weight-bearing joint exercises, 3 to 6 times the individual's body weight in force while walking. Both inactivity and excessive exercise can lead to premature breakdown of the joint cartilage, so we don't want people doing excessive exercise. That's not going to help the situation. We really encourage things like walking, mild jogging, even cycling or swimming, provide the best benefit for keeping the bones, the muscles, and the joints strong and functioning properly. And also to try to maintain good posture and proper body mechanics, and to avoid repetitive stress on joints, and stopping an activity when you start to feel the pain, and of course avoiding injury to the joints. So those are kind of the guidelines that we really encourage to people to follow when they've been diagnosed with osteoarthritis. Early treatment is essential, and of course educating the person about osteoarthritis, because it is a normal aging process. It may be suggested to use canes or crutches or walkers if a person becomes extremely unsteady. The use of assisted technology will help with functional ability. Sometimes it's very helpful to apply heat to painful joints, or use cold applications to reduce the swelling and the pain. And PT and rehabilitation might also be suggested to keep those joints moving and to slow down the progression of the disease. As far as diagnostic testing, obviously it's important to understand the person's medical history and of course to do a physical exam on the person. But one of the most commonly used diagnostic testing is an x-ray of that particular joint, which is giving the person the worst problems. But other tests may include an MRI, some ultrasounds, blood test, and some joint fluid analysis. And what the x-ray is going to show is that there's that narrow space between bones, indicating a lack of cartilage where the person starts to feel bone on bone. And unfortunately, though, those x-rays may not show signs of OA until significant cartilage loss has occurred. And again, the x-ray can show if the person has developed bone spurs or other bone damage. There's really no specific blood test that conclusively tell you have OA, but they can rule out other causes of joint pain, such as rheumatoid arthritis. And the joint fluid analysis is used to detect inflammation and the presence of any type of infection, or even if they have what we call gouty arthritis, or an increased level of uric acid. So people ask the question, is surgery a possible treatment for osteoarthritis? People that really have severe arthritis that is not managed by medication and non-pharmacological interventions may actually be a good candidate for surgery, just depending on what joint is involved and to how much damage is involved with that joint. There are several types of surgery. Arthroscopy surgery, joint irrigation, joint resurfacing, ostomy, joint fusion, and arthroplasty. And what that surgery is basically there to do is to remove the damage and hopefully cut down on the pain and hopefully restore a little function to that joint. This is all in your book, so you might want to read about each one of those types of surgical procedures that may be done. And then, of course, there's always the pharmacological therapy that obviously you're learning in Nursing 123 to correlate with this disease process. When we talk about non-pharmacologic therapy, remember this is a progressive disease. So it's really important that we can early detect and treat osteoarthritis to improve the quality of life for an individual. And I've kind of mentioned some of those treatments. Sometimes simple analgesics, over-the-counter analgesics. And, of course, sometimes heat and cold applications really do help a lot. And, of course, weight reduction, rest, and really learning about the disease and not to overdo it and how to cope with it. And really, if the person really has issues with being unsteady and incredible stiffness, many of these appliances really do help keep the patient much more steadier when they ambulate. Remember earlier I talked about obesity, and that really is a major contributor to OA development because that excessive weight really increases the force of those weight-bearing joints. Also, it's important that people with OA get adequate sleep and rest. Arthritic pain may interfere with nighttime sleep, so the nurse should teach the patient about good sleep hygiene, which we learned in Nursing 100, and we talked a little bit about it with day 1 as far as stress and coping. There's a nice chart on page 951 in your book that really talks about exercise guidelines for patients with OA. This is really a very important part of the treatment of a person with OA. Exercise is an important aspect of nursing care for patients that do have osteoarthritis. Exercise for not only these patients, but for anybody, will increase flexibility, help improve blood flow, and help the patient lose weight, and also improve their mood. And it gives the types of exercises which we would teach our patients about. Please be sure you read that: stretching, active range of motion, balance and agility exercises, low intensity, such as isometric exercises, isotonic exercises, and low impact aerobic exercises. And that would include walking, cycling, or swimming. Those patients with OA do very well with. There are some known complementary health approaches to help with osteoarthritis, which may include acupuncture, massage, or gentle exercises such as Tai Chi or yoga. Also, the use of glucosamine and chondroitin for OA has shown mixed results in some of the clinical trials, with most indicating that these nutritional supplements aren't much better than if they didn't take anything at all. Even some stem cell therapy has been used, but that's still under investigation. And it's important to look at the lifespan consideration, starting with children and adolescents. Some kids can develop juvenile OA, which is usually secondary and related to some kind of congenital abnormality or some type of genetic condition or joint injury. OA can occur in pregnant women because of the increased weight due to the pregnancy. Pregnant and lactating women should be informed of the risk of any medications they are taking. especially a medication such as Celebrex, can have a known risk during pregnancy. There are other medications also that are very dangerous to be taken during pregnancy and when a woman is breastfeeding. And of course, we kind of associate OA in the older patient, and usually what they'll take is acetaminophen, which is the first-line medication for older adults because of its efficacy and its safety. Really, narcotics are safer than the NSAIDs for older adults, and usually are considered a second-line choice. Because of the risk of polypharmacy, a complete assessment of medication history and current medications is necessary before anything is prescribed for patients with OA. So that's why we really encourage the treatment of exercises and a lot of these other complementary health approaches, such as yoga or Tai Chi, will help increase the mobility of the older patient and help also to reduce their pain. Again, what do we teach these patients when they go home? Obviously, we want to encourage the person to make their home safe, avoiding clutter, making sure there's handrails, and making sure that they can reach all the items that they use frequently. Really understanding what OA is about and learning about exercise, but to start off slowly. Avoid excessive or repetitive use of joints. Practice good posture and avoid soft furniture that require excessive effort to get out of that particular piece of furniture or to stand. And patient may be educated about pharmacological and non-pharmacological approaches to manage their pain, and balance periods of activity with periods of rest. So what I want to do now is go over the practice questions on osteoarthritis and just let you think a little bit about what information I provided to you. Hopefully you'll go ahead and read your assigned reading pages, which really there aren't that many. And so let's go over these questions, all right? An obese client with degenerative joint disease is being managed pharmacologically with aspirin therapy. The nurse determines that additional teaching is needed when the client makes which of the following statements? Number 1, I will take my aspirin when I have extreme pain or stiffness. Number 2, I use heat sometimes to help reduce my pain and stiffness. Number 3, I frequently examine my stools for bleeding. And 4, I started an exercise program to lose weight. All right, so let's look at the answer. What do you think it is? I'll let you think about it. All right, the answer is number 1, I take my aspirin when I have extreme pain or stiffness. So let's read the rationale of why that is something that needs to be clarified with the patient. Aspirin therapy is continuous and is effective only if therapeutic blood levels are reached. It is not taken intermittently. The other statements are appropriate self-care measures when taking aspirin for osteoarthritis. All right, question 2. The nurse collects data from a client with suspected osteoarthritis. The nurse elicits information that will confirm which of the following manifestations of osteoarthritis. So what will you find with a patient who has developed osteoarthritis? Number 1, an elevated sedimentation rate, dull, aching pain in the joints, elevated white blood cell count, or a positive rheumatoid factor. And the answer is number 2, a dull, aching pain in the joints. So let's read the rationale behind that. A dull, aching pain after rest or intensified pain after activity with stiffness is definitely a characteristic of osteoarthritis. An elevated sedimentation rate and positive rheumatoid factor are characteristics of rheumatoid arthritis. There are no lab tests that diagnose osteoarthritis. An elevated white blood count is not characteristic of this disease. All right. All right, question 3. A 63-year-old client has recently been diagnosed with osteoarthritis, and the nurse is teaching the client about activities to manage the disease. The nurse includes which of the following in the teaching? Number 1, ice painful joints for 60 minutes. Number 2, perform vigorous exercise. Number 3, take cod liver oil as a supplement. And 4, do not overuse the affected joints. And the answer, as I know you all know, is 4, do not overuse affected joints. Once a person develops pain, they should stop. That's when they've probably done too much. Symptoms of joint pain and swelling will increase if the affected joint is overused or stressed. Ice and heat are acceptable for a maximum of 20 minutes. Mild exercise balanced with rest is best for the affected areas. Now that's really all I have on those questions. What I want to just advise you now is to make sure you view the video in Canvas on scoliosis. Dr. Joris gives a nice presentation of scoliosis, and there's also a bit of reading to do. It starts on page 908 and goes to 913. It's only 5 patients. Remember, scoliosis is a lateral sideways curve of the spine. It can either be C-shaped or S-shaped, and we consider it to be mild if they have a 10 to 20 degree curve, moderate 20 to 40 degree curve, or severe if it's above 40 degree curve. It can be classified as either structural or non-structural. The non-structural occurs as the spine bends to compensate for poor posture, differences in leg length, presence of tumors sometimes, adaptation to pain or other physical conditions, usually alleviated by fixing the underlying cause. Your structural is more severe, and it involves deformities of the bone actually in the spine. It's idiopathic, unknown etiology to 80-85% of the cases where there's a normal force on the spine. If it's considered congenital, a person is born with it, and along with the scoliosis, they may also have heart and kidney problems. The most common curve pattern is an R, as a right thoracic curve. What's the risk factors for scoliosis? Obviously, adolescence. This is a time when children go through a growth spurt just before puberty, usually between the ages of 9 and 15. Girls are more likely to progress to a greater curvature than boys. Of people who develop idiopathic scoliosis, about 30% are found to have a family history of scoliosis. Other risk factors are having a neuromuscular disease, maybe such as cerebral palsy or MD, or else someone else in the family has had scoliosis. So how does this problem manifest? It includes a spinal curvature to one side. Usually you'll see the hips and shoulders uneven. There's a difference in leg length, tiredness of the spine, and a prominent shoulder blade, and also a rib hump. Although not common, back pain may accompany scoliosis, and sometimes with severe scoliosis it may cause heart and lung problems, as I said before, which can also cause respiratory problems, where they're more at risk for developing pneumonia and even compression of the nerve roots may actually cause paralysis. The mild curves, which are less than 20 degrees, often do not progress and do not need treatment. Moderate and severe curves, which are 20 degrees to over 100 degrees, will require treatment, especially if the curve begins to progress. Okay? So I talked about the types of scoliosis, the congenital, which is present at the time of birth. And usually there's no known cause for congenital scoliosis, but they do see a correlation in environmental factors. Hypoxia and vitamin A deficiency are leading factors, and others that increase the risk include valproic acid, boric acid, hyperthermia, and alcohol use. And when we talk about idiopathic scoliosis, there are 4 types. The first one is infantile idiopathic scoliosis, and that occurs from birth to 3 years of age. And then juvenile idiopathic, and that's occurring with children between 3 and 9 years of age. And then adolescent idiopathic scoliosis occurs in children between 10 and 19 years of age. And then, of course, lastly is the adult idiopathic scoliosis that may be present from childhood or may just develop as a result of the aging process. So how do we diagnose scoliosis? Through school screenings, of course, between the ages of 10 and 15 years old. X-rays are pretty much the most common imaging testing used to definitely diagnose scoliosis. Using an X-ray of the spine, physicians can determine the angle of the curve using the Cobb method, C-O-B-B, the Cobb method. And what this does is it uses lines drawn from the end of vertebrae to estimate the degree of the actual curvature. The angle found at the intersection of the 2 lines is called the Cobb angle. So definitely read about that. And of course, other imaging testing might be a MRI, a CAT scan, or even a bone scan. And of course, we know that surgery is definitely an option. It's definitely available for patients with a Cobb angle of greater than 50 degrees. And surgery is usually done on patients whose curvature progression is not slowed down by putting on a brace and whose bones have stopped growing. And if this curve is very severe, at least 45 degrees, before the child has stopped growing, surgeons may insert a rod that can be adjusted in length as the child grows. And adjustments can be made on that rod approximately every 6 months. So read a little bit about that. And then, of course, we don't usually treat scoliosis with medications, but if there is some discomfort, we encourage the patient to take over-the-counter medication, such as acetaminophen for mild pain. And obviously, the non-pharmacological therapies will just depend on the Cobb angle, what they got, with how much curvature is present, okay? Patient may have a spinal fusion, or also braces may be used. But those can be very taxing on a person because the braces should be worn between 12 and 23 hours a day. And of course, what teenager or adolescent wants to wear a brace that much during the day, because it will affect the way they look and appear to their peers. So just wanted to bring some of that information to light. And again, be sure that you listen to Dr. Joris's short little video on scoliosis. Well, this is all I have to say about our concept of mobility and our exemplar of normal versus abnormal mobility, and of course osteoarthritis and scoliosis. Thank you for your attention. You guys did a great job on the practice questions, and just continue looking over the information. Thank you, and enjoy your day.